Academy of Host Integration, that because we wanted to push it and it was very successful. We did some nice discussions.
Guys, I'm on
Massimo Simeon attended it. I don't know if you saw it, but it was nice to have it today.
Listen, if you would be quiet for 4 minutes, I'm trying to Facebook Live. I just want to know what kind of sound we have. Okay.
Right.
Dear friends all over the world, and greetings from Berlin. We here at Quintessence Publishing are very proud to announce our new webinar series, the Quintessential Thursdays.
Every week at 5 p.m., we will feature 3 of our authors in 3 short lectures and a moderated discussion. Today, I can announce Hendrik Domisch from the Charité in Berlin, who will be moderating this first session together with our friends Istvan Urban, Giovanni Zucchelli, and Daniele Cardaropoli. I wish you a lot of fun, and I hope you learn something. Dear
Hello, everyone. I think that I'm on now, and I would like to welcome you very much, also from Berlin, for tonight's session. I think we have a very special event tonight with 3 extraordinary speakers. They are all well known in the field of dentistry. I think that we are all very excited, and now I'm thrilled to present to you our first speaker, who is going to be Professor Daniele Cardaropoli, who is doctor in dentistry and holds a certificate in periodontology at the University of Torino. He's also a adjunct professor in periodontology at the University of Catania, and he's scientific director of the Institute for Professional Education in Dentistry. I think he is very well known to everyone in the field, and he will present tonight a presentation to us, short presentation on immediate implants and how to create optimal soft tissue integration. So please, Danielle, I'm very excited to hear your presentation, and welcome.
Thank you, Henrik. It's really a big pleasure for me to be on live this afternoon. Thank you for okay. Thank you for your kind words, and thank you to Christian Hase and all. Okay. Thank you to Christian and all the Quintessential family for having this idea in order that we can share some knowledge this afternoon.
Daniele, I'm sorry, there is some problem with the sound. We're trying to fix that.
Yeah. Tell me when I can go on.
All right, go ahead.
Okay. So I was just saying some words. It's really a big pleasure for me to be here live on Zoom and on the Facebook platform this afternoon. For sure, for us, it's not so easy to go through these difficult moments, not only in Italy, but all around the world. We have some challenges for sure, but I'm sure that we will be able to get through these challenges. So thank you, Christian, for having this idea to join us. I know that a lot of countries are connected and they can see our webinar this afternoon. A big pleasure to share this moment with Giovanni and Istvan. I try to share my desktop. Okay, perfect. So this afternoon, I will try to speak a little bit about immediate implants, and I will try to share with you what kind of knowledge that we have today about the placement of implant in fresh extraction sockets. But first of all, for sure, I have to say something. This is the big hurt that we have here in Italy. You know that we have a lot of problems with the pandemic, but you know, when the going gets tough, the task gets going. So keep strong. We are, I think we passed the peak now, and so we can see the light at the end of the tunnel. So speaking about implant therapy, we know that for many, many years, we focused about what kind of implant surface we should use, what kind of relationship we have between the bone and the implant. And also when we speak about fresh extraction socket, we are focused about the healing of the bone tissue. Well, everybody knows this paper that was published by my poor brother Giuseppe some years ago, but is still a paper that continuously is part of the literature when speaking about the dynamics of bone tissue formation in tooth extraction sites. We know that the healing always starts with blood clot stabilization. And we also know, thanks to this paper published by Mauricio Araújo, that following tooth extraction, if we wait for a spontaneous healing, we will have a decrease in the vertical dimension of the ridge of about 2.3 millimeters in 8 weeks following tooth extraction. So basically what we have after we have extracted a hopeless tooth is what we can see here. So we have basically the blood clot stabilization. And after blood clot stabilization, we have the clot breakdown with the fibrinolysis, and then the formation of a matrix. This matrix will be transformed in the first stage of a mineralized bone, that is the woven bone. And then the woven bone will mature itself and will be transformed in lamellar bone. And so we have a good kind of healing when we speak about the bone and when we speak about the quality of the bone tissue that we will have. But unfortunately, we will experience a lot of remodeling when we speak about the volume of the ridge. And so both in the vertical and horizontal dimension, we will lose a lot of volume. But we know that not only the bone is important. I think that today everybody agrees that the soft tissues are important as the bone when we want to provide long-term stability around our implant-supported restoration. And for this reason, today, not only we speak about the biological width, and we know that there are some similarity and differences between the natural tooth and the implant. But most commonly, we like to speak about the soft tissue barrier around the implants. This barrier is able to provide stability and keep the tissues healthy in the long term. So we know and we agree that today, soft tissues are not important just or only because of the aesthetic and the aesthetic outcomes, but they are really important in order to provide the stability of the bone. And for this reason, always we try to give a minimum height, or we want to speak about thickness of the soft tissues around the implants, in order also to limit the remodeling of the bone. And so in average, if we want to speak about the numbers, we think that at least 2.5 millimeters of bone we need, of soft tissues thickness, sorry, we need to maintain also the marginal bone level stable over the years. So we changed our concept, the soft tissues, not only important for the aesthetic outcomes, but also for the maintenance of the stability of the bone. And so we can see here in this images. This is immediate implant placement. It is about 5 years after, in the occasion of removal of the definitive ceramic crown, we can see the tissues very stable. We have the papilla. And from the point of view of the bone, we have stability. So also when we speak about immediate implant placement, this concept, the thickness of the soft tissues and the possibility to provide thick and healthy soft tissues around the implants is really, really, really important. And when we consider patients, we have to, we have to keep in mind everything. We have to keep in mind what we know, what we can do, what is our knowledge, but also we have to keep in mind what are the expectations of our patient. Giovanna, she has this big problem on the upper lateral incisor. Unfortunately, it is an hopeless tooth. And so if we think about her, for sure, she asked to have an immediate replacement, an immediate crown. Maybe it's not important that it is an implant supported or not. She wants a crown, but we know that in this specific situation, we will never go with a bridge, with a conventional bridge. So the only option is maybe is the implant. But we have to be sure that implant is the perfect and the best decision for our patient. And so we have to make a diagnosis and a treatment plan. And so we know that not always we can place an immediate implant. We, together with my good friend Paolo Casentini, we published this textbook last year, Soft Tissues and Pink Aesthetics in Implant Therapy. And we tried to provide a new classification for post-extraction sites. We have 4 different classes: class 1, class 2, class 3, and class 4. And class 1 is the site in which we have both the soft tissues and the buccal bone plate that are intact. In this specific situation, we can go home with immediate implant placement because the tissues, both the bone and the soft tissues, are intact, are optimal. With class 2, it's not possible to get primary stability. In class 3, with the buccal bone plate shows a big resorption, and we can have also gingival recession at baseline. In class 4, we also have a large periapical lesions. So we know that from the point of view of the clinical indication, only class 1 is suitable for immediate implant placement. And Giovanna, she is lucky in this situation because the buccal bone plate is intact. It is thin, for sure, we can see here, but it is intact. And so with a flapless approach, we try to be minimally invasive. We extract the tooth, we place the implant, always prosthetically driven. We graft the bone to implant gap in order to maintain, to compensate for the marginal bone remodeling. We know that grafting at the time of implant placement, we give a concept of healing that is similar to what we have with alveolar ridge preservation. And then we are able, since the implant had a good primary stability, more than 35 Newton, to provide an immediate restoration. Mostly, we try to keep this kind of immediate restoration skew retained. The healing is after 3 months. After 3 months, we disconnect the provisional and we can deliver the immediate, the definitive ceramic restoration. And if we compare the baseline, the soft tissues, the interdental papilla, both the mesial and the distal, we see that there are not many changes between what we had before tooth extraction and what we had 1 year after the delivery of the definitive crown. And also the gingival profile has been maintained stable. So this is what we want to do and what we aim to provide to our patients. Stability of the soft tissues when we start, for sure, with tissues that are in an optimal level at baseline. So when speaking about immediate implant placement, basically, we have three different situations that we have to take under control, to keep under control. The three-dimensional positioning of the implant, the grafting of the bone to implant gap, and the possibility to provide an immediate restoration. The three-dimensional positioning is really important because we know that we should be able to engage the apex of the implant in that triangle of bone that usually is apical and palatal to the natural apex of the tooth. And about the bone to implant gap, we know that if we fill this gap with a slow resorption biomaterial, we are able to compensate the marginal bone remodeling in average for the 93, 95% of the original volume. And then with the immediate restoration, usually we are able to maintain the original contour and profile of the soft tissues. So there is no relationship between the osseointegration and the delivery of the immediate restoration, but the relationship is more with the maintenance of the soft tissue contour. And here we have Paula. She's 67 years old. Another opeless frontal tooth. This is an upper central incisor. I think it's really important to have a combine at baseline. We can see here that the buccal bone plate is very thin. It should be 0 point something millimeters, but it is intact, thin, but there is something. So we know that we have published this randomized controlled clinical trial last year. Even if the buccal bone is thin, we can maintain the volume. So with an opeless approach, flapless, we are really conservative and minimally invasive. And so also Paula, she is in class 1, so we have an indication for immediate placement. And this is the kind of approach that usually we use. So flapless extraction, we keep the original architecture of the soft tissues. We debride the socket. We try to remove the epithelium in order to expose the connective tissue. We check the integrity of the buccal bone plate again, and we prepare for implant placement. Always implant placement will be prosthetically driven, and we try to place the platform of the implant around 1 millimeter apical to the buccal bone level. And so this is the implant site preparation. In order to increase the primary stability, we under-prepare the site. And we can see here that, as always, the implant is moved in the palatal direction, and then it is inserted. We are 3 millimeters below the gingival level. We have a gap, and the gap is filled with the slow resorption biomaterial in order to compensate for marginal bone remodeling. So we adapt the knowledge that we have coming from the alveolar ridge preservation studies. And in order to improve also the soft tissues healing and the wound healing, we use some enamel matrix derivative around the gingival tissues before delivering the immediate restoration. So this is where we prepare for the implant site on the buccal bone plate, far away from the buccal bone plate, and we prepare it on the palatal bone. in order to have at least 2 millimeters of gap on the buccal side. This is the implant, and the implant, the gap that is filled with this kind of slow resorption biomaterial. We deliver an immediate restoration that always should be screw retained. And look at the tissues that we have after 3 months. Since it is a flapless approach, we think that after 3 months, we can switch from the provisional to the definitive ceramic restoration because the tissues are stable. And this is the thickness that will give long-term stability. And we can see the difference between baseline after 1 year. And in the last minute of my presentation, I want to show you something new. We are working on it, a new concept. We started to think about the possibility to fill the gap before implant placement in order to be sure that the gap is fully grafted 360 degrees. And this is possible using a specific concept and specific instruments. This is a short video that shows what usually we do. So we try to have a flapless extraction in order to be really conservative, minimally invasive. We debride the socket. We remove also, in case of periapical lesion or the inflammation tissue. This is really important. I like to remove also the epithelium in order to expose the connective tissue. And we start implant preparation on the palatal side. So we will engage the implant in the triangle of bone that is apical and palatal to the apex of the tooth. And then before implant placement, we start filling the gap. What will be the gap? This time is not the gap anymore, but what will be the gap? And so with this kind of biomaterial, we fill and we push, and we are able to push both in the apical and the buccal direction. We try. It's important that we don't leave any granule of bone substitute in the apical portion, and then we are able to engage the implant. And so the last case, this is Benedetta, 36 years old, a young, beautiful lady with a broken upper central incisor. She is in class 1, so we can deliver immediate restoration. And it is just 1 minute, another short video. We can see the approach. It is really standardized. So we remove the crown, we remove the root. We try to be conservative to the intradental papilla and the soft tissues. We expose the connective tissue here. We prepare the implant on the palatal side. And then we can see here, we stay far away from the buccal bone plate. This is really important. Implant site is prepared. We drill according the implant system that we use. For sure, when we want to perform an immediate implant placement, it's better to use conical shaped, conical tapered implants in order to increase our primary stability. And before implant placement, we start to graft what will be the implant to bone gap. Now, the biomaterial has been grafted. We check that we don't have granules in the implant site, and the implant will be inserted. So this is the immediate restoration. After 3 months, look at the tissues that we have. They are so thick, and they will give a lot of stability. we switch to the definitive crown, and this is the final outcome 1 year after. I think the situation is better now that at baseline and everything is stable. She's really happy. We know that this approach will work both in thin and thick phenotype without differences. So with this kind of approach, we know that we can provide stability, good aesthetic outcomes, moving from natural to that for sure is hopeless, and with a flapless extraction, with a prosthetically guided placement, with the bone to implant gap that will be grafted, and with an immediate restoration delivering, we are able to provide long-term stability, not only in the term of marginal bone level, but also, and it is really important for the soft tissues aesthetics. So this is really important because this is the concept of predictability, and Aristotle has introduced this more than 2,000 years ago. Henrik, I think I'm done with my presentation. Thank you.
Thank you so much, Daniele. I hope everyone can hear me now.
I hear you.
All right, am I back on air, so to speak? So thank you so much for this very interesting presentation. I think there were a couple of very new things to most of the people in the audience, and we actually received quite a few questions regarding your presentation, and there's there are some questions.
May I have also a question?
Yes, of course you can have a question.
Henrik,
I don't know.
I want to have the first question from Giovanni.
All right, so you should receive the first question from Giovanni. Okay, you're on. Giovanni, please ask your question.
Yeah, why the soft tissue is so thick in your drawings? Why they're not so thick in your surgery?
You mean at baseline or at
no, in the drawings?
Yes, at the beginning.
You know, in the drawings, the soft tissue you have at the buccal aspect is extremely thick.
They are just drawing, Giovanni.
Ah, yeah.
But in the reality,
it's not so. That's what I want to speak about. In the reality, I don't find so thick tissue.
In the reality, usually we have thin tissues, and but what we measured in this randomized trial that we published last year, that also when the tissues are thin, if we are able to maintain the original architecture, and so if we are able to avoid any kind of flap elevation, and we move the implant far away from the buccal bone plate in order to have a gap distance of at least 2 millimeters. But when I say at least, it is really at least. So usually, as I shown in the 2 cases, I try to stay 3 millimeters, maybe 3.5. And to do this, it's better to use implants that they don't have a wide platform. I don't think we need wide platform implant in the aesthetic area.
Yeah, I agree, but you also have to agree that the thickness of the tissue, what we are speaking about is not at the level of the bone, but we are speaking supra-bony, should be at least 2 millimeters thick because they are not attached to the crown. And so how is the thickness of the tissue at the beginning when you make flapless implant installation? How was the thickness of the tissue at the beginning? Let's say 0.5, 0.8, 1 millimeter? No more.
In patient with a thin phenotype?
Even in the thick, you know, thick biotype is 1.5.
Yeah.
Is it thick enough for implant?
It is.
It is?
Yes.
I'm not so sure.
Well, I can tell you that
it must be increased. Not surgically, I mean. Maybe
not
by
surgically.
leaving blood. No, I mean.
No,
so 1.5 millimeter.
it will be increased during the healing phase.
So it's not thick enough. It must be increased.
Yes, but not with the surgery.
No. I don't say with the surgery, but
during the healing. During the healing. I don't know if I can show you this.
No, it's just to speak.
No, because now you know that.
No, well, we have to leave time for people to discuss.
Yes,
not
I think we should also ask some questions from the audience.
Can you see the picture?
Yes.
Yeah, I saw it.
So this is without any soft tissue graft. And it is 3 months after implant placement. And the baseline,
I saw it.
Look, the soft tissues was, I try to go back.
No. Don't lose time.
Okay. Should we move to some of the questions from the audience?
So I agree with you, Giovanni, that the tissues will become thicker, but not with a graft. I mean, not with a soft tissue graft. I think it's really important to move the implant platform in the palatal direction. If you stay close to the buccal plate, you're done. You will have a recession, and then we will need you.
All right, this is a very good word to connect to questions from the others. There are multiple questions regarding more or less same issues. It's about the graft material. People ask themselves what kind of material you use. Is this reasonable to use a membrane with it, or can you use it without membrane? I just try to condense the questions now to save a bit of time. And also in the same matter, they were asking themselves what type of instrument do you use to condense the bone and check whether there is graft material apical to the socket, prepared socket.
Okay, regarding the biomaterial, my preference is for a xenograft that is made of bovine bone blended with a 10% of collagen. So there are small blocks that specifically for this kind of small defects like the bone to implant gap will help us to graft the gap accurately. So, but at the end, it's a xenograft, a bovine bone, in order to give us osteoconduction and a slow resorption rate, because we want to maintain the volume of the alveolar ridge. So giving the same concept that we found about alveolar ridge preservation. Usually, if you go with an immediate restoration, we don't use a membrane because we seal the tissues at 306 degrees with the gingival portion of the restoration. But if you don't go with an immediate restoration, and for example, you will screw an healing abutment on the implant platform, it's better to protect the graft with a membrane. You can trim a membrane and place the membrane between the healing abutment and the graft. And
I think this is a very nice answer. And what type of instrument do you use, and how do you?
Well, that instrument that I used and that they were able to see during the videos is a specific instrument that was created to graft. It's a bone plugger. It is called the Cardaropoli.
Of course.
Yes, because I did it, and that the apex is a round shape, and the instrument is tapered. So when you push, you create two vectors of forces, one in the apical direction and the other one in the horizontal. And so you can compact the bone graft on the buccal side. And with the same instrument, you check the apical portion of the implant site, that you don't have to leave any granules inside. Otherwise, we will be very hard to engage the implant and get primary stability. Also, because when you place an immediate implant, the majority of the implant stability will be get in the 3-4 millimeters in the apical portion.
Yes.
Really critical.
And there are people asking themselves, how do you choose the diameter of the implant that you place in these situations, and how deep would you place the implant? So where is the shoulder in the end after placement? I think this is also a condensation of a couple of questions that we had here.
Okay. Many years ago, we started to think, and we have a lot of literature telling us that the implant platform should be placed, I don't know, 3 millimeters from the gingival margin. But now we don't use the gingival margin as reference point in case of immediate implant placement, okay? So in case of immediate implant placement, the reference point is the buccal bone plate, because we don't want to leave the implant neck without bone. And so the implant neck will be placed, the implant platform, around 1 millimeter apical to the buccal bone plate. So that is the reference point.
All right. Okay. And the choice of the diameter of the implant would be
good, very interesting question. I think that today we start measuring the diameter of the crown at the CEJ. Okay, so start to think what will be the diameters of the alveolus in the buccal palatal dimension. And then we have to think if we have an implant diameter suitable to be placed there in order to leave the gap. So it's different from what we did at the beginning, starting with the idea that in an upper central incisor, we need, I don't know, a 5 millimeters implant, and then following that decision, the diameter implant, everything else will follow. No, now we think differently. It's more important to have the gap, the bone to implant gap. And for these reasons, we can use also smaller diameter. So something like 4.1 millimeters for an upper central incisor is more than what we need. So usually these are the diameters. And I also changed my way of thinking for your question.
Yes, super, very, very nice. Thank you so much. There were also some questions regarding emdogain and how to deal with the soft tissue. Why would you de-epithelialize the tissue? And I think that maybe you can.
Everything is related to the wound healing.
Yes.
This is an interesting topic. We are working
maybe short answer to that.
Short. So everything is made in order to enhance soft tissue healing, to have better soft tissue, so exposure of the connective tissue. Also, the use of the enamel matrix derivatives is in the same. We try to use enamel matrix derivative, then we use it in the protocol that then we publish in a randomized controlled clinical trial, and we are working a lot. Because we know that enamel matrix derivative started its history for periodontal regeneration. For sure, we will not regenerate any kind of periodontium around the implants, but is able to enhance soft tissue healing around implants in the marginal level. So that is the rationale for using AMD.
Yeah, super. I think maybe one little short thing to also condense a couple of questions, or at least some part of some of questions. People would like to know, what is the timeline? So when you place the implant and then you do immediate, or you do an intermediate restoration, and when do you put your final restoration on it? How long do you wait if you make this augmentation, this bone graft augmentation?
In an ideal case, in which we go with a flapless approach, flapless extraction, and immediate restoration. After 3 months, we know that we already have osseointegration, so the implant is osseointegrated, and we have soft tissue stability. So we can move from the provisional to the definitive, but only if the extraction was flapless. But we know that not 100% of the extraction can be flapless. In that kind of situation, if we have to elevate a flap, maybe for to engage the root, to be able to extract the root, it's better to wait a longer time in order to have stability of the soft tissues.
All right, so I think this answers this very nicely. So we got actually a ton of questions, and it's very hard to keep up with all the questions and two sides. But I think we covered at least some of the questions that people would have on your presentation. I think it was a very nice and clear, straightforward presentation. I really love the cases that you made, and have to thank you very much. You know, our hearts are with you in Italy. I know that you have going through the hard time, and so I think it's almost now applies to whole the world, the whole of the world. So I think, but our hearts are with you in Italy. So thank you, Daniele. It was
thank you.
Very, very nice. Again,
thank you.
Very nice. So I thought I would like to now switch to our second speaker for tonight's session, and he is Professor Istvan Urban, and he is also a very well-known professor in dentistry. He received his DMD degree and MD degree from the Semmelweis University in Budapest, and he completed a full-time program in oral surgery, which was also in Budapest, and then he went to the US and had an internship at the UCLA, University of California, Los Angeles, and he graduated then from Loma Linda, and he's now there an assistant appointed professor. And he is very well known in the field of implant dentistry, and also in regards to how to cope with the hard tissues. And so we heard a little bit of soft tissue issues and how to deal with the soft tissues around implants when you do immediate implants. But now we're asking the question, what's happening when there's bone missing bone, and how to cope with hard tissue augmentation. So dear Istvan, so if you're on, I would like to start your presentation. Yes, that's working very nice. And the stage is yours.
Thank you very much, Henrik. Thank you, everybody who's attending the presentation. I gave the title of the presentation, Vertical Ridge Augmentation. And I think this topic is going to be very interesting. And I'd like to discuss one type of defect that is not really evaluated in the literature. What we see in the last 20 years that we have patients who have, basically they're getting younger and the defect is getting larger. So you can see on the left side that this patient already had an implant, and that implant was doing great for a while. And I heard that after about 5 years, within 2 years or so, it just broke down. So what is the reason for that? Because now this patient's still young and she's interested in regenerating the bone, but I'm requiring that my implant in regenerated bone is going to be better than this implant was in native bone. So how do I think about that? Well, let's look at that implant. Well, that implant looks great on the left side, but I noted from experience that when they put that implant in, the bone was very, very likely so thin that maybe that implant doesn't have any buccal and doesn't have any lingual bone. And that sometimes works perfectly, but in our recent documentation of our own cases, this is what we looked at. We placed implants into regenerated bone, and you can see the black line, and you can see the follow-ups for 10 years, and the black line is a little bit going downhill, but you can see the blue line. The blue line are implants that we placed mostly in the premolars, in the maxilla, in an average of 6 millimeters of bone. So we had a little bit of bone plate on the buccal of these implants, and this is how they look after 10, and this is how they look after 12 years. And you can see here, even after 10 years, between 10 to 12 years, the two lines have a difference. And the bigger problem issue is that the blue line has a very, very big range. So what happened to this implant, I believe, is that this implant didn't have any buccal, very likely didn't have any lingual bone. On the lingual, it is very difficult to clean. So then there was some inflammation, and slowly, and usually that breaking point is after 5 years. It's sometimes it's 7, 8 years, you see that boom, that implant is starting to break down. So that's good news, because we may be blaming that was the problem, and then we can do a better job regenerating bone. And actually, this theory that I'm telling you, and basically is not only a theory, it is in agreement with Wenström, and they did an RCT, and they found very similar, and also Carmagnola. So there is reasons to suggest that over time, this uneven outline of the marginal bone around implant is leveling by bone remodeling process in the reduction of bone height of the proximal surfaces. Okay, so let me explain that again. Here's 3 implants. This patient came to my practice, and this patient, and these implants are looking great. If I look at the left, this implant looks good. The other 2 implant also looks good. However, those in the back have a little bit of remodeling. Well, why is that? That can be normal, but that can be also that what I just explained. You know, this patient had a large bone graft, and this large bone graft, it looks like it works well, but look at the CT scan, it doesn't work so well because this bone completely dissolved. And let me show this to you again, completely dissolved. When I saw the patient came to the left side. I saw the patient, I took my periodontal probe, there's absolutely zero problem around these implants. 2 years later, look at that. The middle implant, no problem. It's a good soft tissue attachment. Distal implant, no bone. So this bone graft didn't take, you know, the function and the purpose why it was placed there. And it was not visible on the X-ray really well. On the other side, you can see the other side, the patient had a vertical bone graft. That it disappeared also. Both of them disappeared, but you can only see only one at the beginning. And I have to say that the posterior regions, and especially when you're treating multiple teeth defect, is a different ballgame. And the other thing is the vertical defect is much more honest than the horizontal. If you're losing vertical, you see it immediately. If you're losing horizontal, sometimes it's gradual and you don't see it immediately. Sometimes you never see it. And I'm sure that Giovanni will speak about, you know, these things many times, you know, also with single teeth, anterior, that's a little bit of a different ballgame. In the posterior, this is not good news when you have all this gone with around these implants. So we had to treat this and replaced a bone graft and regenerated the mandible. And now you can see what happened and what did we use. Now on the left side, you can see 2 implants. And those 2 implants I used, those are a 15 and a 13-year follow-up CT scans on my autogenous chip grafting. Okay, I did a bone graft, I used some autogenous chips. I can still see a little layer of bone. You look at the right side, I'm not very happy with that. It's very, very, very thin, and I'm seeing already 2 threads of this implant. Doesn't show any signs of biological problems. In the middle, you see a bone graft that I'm doing, an autogenous bone, half of the autogenous bone, and the other compartment is the anorganic bovine bone mineral. Now, when we use that, this is what's going to happen. So let's look at that over time. Why are we using this graft material? 2 reasons. 1, to reduce the invasiveness. Number 2, look at another case that I did a big ridge augmentation. It was completely knife edge. This is at 13 years on 4 implants. 1, 2, 3, 4. Mandible, absolutely knife edge. 8 years later, you see that the contour is completely preserved. And that comes because of the autogenous bone connected to the anorganic bovine bone mineral. So now we have this type of patients today. And this patient has a defect that is, we call the extreme vertical atrophy. So what can I say to this patient? What do we know about the literature on this patient? So you can see here the size of the defect. You can see anatomically what happens. Anatomically, you can tell that here's the nerve, and here's where you're going to usually make your incision. Your flap is going to be 6 millimeters. You want to put in a 10 millimeter implant. So when you want to put a 10 by 10 bone graft, and you have a 6 millimeter flap, and you don't want to damage the nerve. So that is a technical problem. You can also see here that this bone is very, very cortical. And this cortical bone is a very poor host. So I just showed you a horizontal and a vertical defect that the bone grafts disappeared. So biologically, didn't work out. So we have a patient here, and there is a biological difficulty, and there's a technical difficulty. And the biological difficulty is as difficult as the technical difficulty. Okay, so we have to be able to close the flap, and we will have to be able to make bone and create bone here. Now you can see on the X-ray that there is no tenting screws whatsoever, no implants, nothing. I mean, you cannot place a tenting screw because you're going to put the tenting screw into the nerve. So basically, you're just doing a particulated bone graft. Question: what other technique can you use? How can you put a bone block, with a navigation device maybe and go around the nerve? And then how is that going to vascularize? Now, if you look into the literature, well, we published a paper last year in the Journal of Clinical Periodontology, a review paper with a team who I completely want to give them the credit because they did the majority of the work. But what we found is this: doesn't matter what type of technique you use. In the literature, you're gaining an average of 4 millimeters of vertical height. Now, this patient in the middle needs much more than that. Complications and all that, mostly guided bone regeneration has been utilized with probably the least amount of complications. But according to the literature, this middle defect cannot be treated. And there can be two reasons. A biological reason, that you put a bone graft and this cortical bone is not going to be enough for the blood vessels to grow up. Some people think that the blood vessels change their mind after 4 millimeters. They grow 4 millimeters and then they say, okay, I turn back. Okay, so for whatever reason, 4 millimeters is the limit in the literature. But I think there can be another reason for that. And that reason can be a technical reason. Remember the 6 millimeter flap and the 10 by 10 bone graft. So we started to investigate that, and we have done, preclinical and clinical research to understand how this vertical bone is going to form and how we should be able to maintain that. So here's a study that we did early on when we look at different areas in the mouth: anterior, posterior, upper, lower. And what we found that if we put at least 50% of autogenous bone chips, and it's a particulated bone chips, then the bone should stay stable around the implants. Then we looked preclinically what happens with the bone. On the left side, you see a bone graft that I'm placing. On the right side, you see a bone graft after a couple of months, let's say about 6 months after healing. And then you see that was green, and now you see the orange one, and the orange one, you see that this is about 9 months of healing when the real corticalizations begins. And you can see on the outer surface that there's an orange line, how it's corticalizes. Let me explain this to you. So when do you place the implant into the bone graft? Well, the same patient, look at that, left side, right side, patient lives far away. So I'm gonna place the implant. On the right side, I'm going to place the implant about 10 months after bone grafting. Why? Patient cannot come back earlier. Good. Let's look at the bone. I just want to show the bone. That is when the orange line is coming. That is when it's corticalizing. See that? That's the cortical bone. But I want you to see that when I'm going to drill, it's all bleeding. It's not white because of the, it's not vital. It's corticalizing, the orange line. So let's wait a little bit. I just want to show like an occlusal view. This is a complete knife edge. This has the bone graft material incorporated with autogenous bone. We expect, and I showed you CT scans, with this type of bone graft, it is not going to disappear. Now, okay, so let's look at the right side at the same time. The right side is about 6 months. Okay, the left side, you see the cortical bone. The right side, you're going to see no cortical bone. You see that still we're within the green zone. Okay, some people say that I can place my bone graft, my implant in 3 months into my bone. Well, we can explain at the end what is that. It's not. The bone graft is going to mature regardless, the same speed as like in human we call it like a pregnancy. Okay, so then we looked a little bit more deep in there and we evaluated different membranes. And what we found that the adaptation of the membrane is very important. So we created like a hybrid membrane, some holes for vascularization and some solid membrane to stabilize and to adapt around the bone. And here, as you can see, a case. I place like here a substitute to thicken the tissue. And what I see here is that the bone is very, very stable around this implant. It's early, let's say 1 year of loading. Here's another one. Here's a 75-year-old patient. And we always saw in every single vertical cases, bone loss or about at least 1.5 millimeters. And you know, with the better vascularization, we get better bone stability. So what do we know now? The blood vessel, I don't think it's changing its mind after 4 millimeters. But if we allow the blood vessel to go from the other side and from this side, we're going to get better bone quality. Vascularization is important. Now, so now when you look at the posterior mandible, we see that we have plenty of cases and we love the posterior mandible. Posterior mandible, by the way, is also in vertical augmentations, by the way, it's an Italian technique, was developed by Professor Simeon and Tinti and co-workers and Dr. Jovanovic. And you can see here, before and afters, you need a healing for this, okay? And you need to advance the flap around. On the right side, you see the mental foramen, and you see that I'm advancing the flap, but I'm not looking at the mental nerve. You see on the middle and the left that I'm advancing the lingual flap. Good. We know the anatomy. We know that the blood vessels are embedded, the nerves are embedded in the dense connective tissue. It's also known that the muscle is inserted in a very thin line that's called a mylohyoid line that we should not disturb, because then we're going to connect to the cervical spaces, which would not be very good if you see like an infection. You see here the vascularization. The left side is the classical sublingual artery. The right side is the side when it's actually the facial, a branch of the facial artery is performing the vascularization of this area. So this is below the salivary gland, and you can see how the little arterioles are going around. We're very lucky because everything is embedded in a dense connective tissue. We believe that this dense connective tissue was developed by nature millions of years ago to protect the patient from the dentist. So you can see the anterior, how the end in the anterior endpoints of this. Okay, so based on the anatomy, we're going to do the modified lingual flap advancement. In the literature, this is the type of patient that is really well documented, which is about a 5 millimeter vertical defect. And this patient has very good teeth. We did the bone augmentation. We placed the implant. We had absolutely just mucosa. We enhanced the keratinized tissue around these implants and restored. And this is the soft tissue around these implants. And we have seen a little bit of remodeling with all types of membranes, even in cases like this. But we're doing better than that. Here's another one, a bone graft before and after, and I have the bone, and I have this 15 years later in a very old style implants. Okay, so what you see here on the left side is the bone that is corticalized. Remember the orange line that we looked at the preclinical study, how this is going to be the real bone. So now what does it tell me? That it tells me that if I will be able to develop this posterior mandible in a way that is not going to disappear first like this, then it's going to maintain the width, then it should be able to maintain also the height. So let's go back to this patient. This patient is the patient that is not investigated in the literature, okay? So we have this defect, and we know that it's a biological difficulty. We're gonna do the so-called safety flap. So we do a large flap, and you can see that the bone is really down there. We expose the mental nerve. We have seen so much attachment loss around the canine that we decided we're going to have to extract. Why not an all-on-4? Patient had periimplantitis. Patient said, I'm not going to lose all my teeth because of 3 implants. So I agree with the patient. And now I'm going to go on the lingual, and we do a first step. The first step is we tunnel and lift the retromolar pad. Second step, look at that. The mylohyoid muscle is attached on top of the crest. What are we going to do? We're not going to detach it from the mandible. We're going to separate the soft tissues from the muscle. So we very carefully start separating. And this is the second zone, the flap from the muscle, keeping the muscle intact. And you can see it here, how the muscle is now more visible and is going to disappear without the detachment. Okay, so I'm just going to separate this. And now we have the distal portion pretty well advanced on the lingual. But the mesial portion is not yet. That's the third zone. We're going to perforate the cortical bone. It's really cortical. I'm pushing through like with a step drill, and still there's hardly any bleeding. It's a problem. Okay, now we're going to fixate, and we're going to select here that was a prototype type of membrane, like a perforated membrane. And we're using screws and pins on the lingual, and this patient needed 4 of them to completely stabilize. And now you see the size of the defect. We took the bone. We used about 60% of the autogenous bone, 40% of the anorganic bovine bone mineral. We fixate. No tenting screws. No, I mean, there's not even any possibility to put any tenting screws, and you don't need any tenting screws. You can just pack the hell out of this bone graft. And you can see the intact nerve that was almost on the crest. And now there's a 10mm bone graft above. Now, the mesial portion of this flap has to be advanced. And now you have to use the back end of the blade because there is a periostal zone. So I'm going to go with the back end of the blade. I have a mini vertical incision, and I'm going to go from here to the premolar. I will identify the any arteriolas. And now you can see that the flap is so well advanced, it's not bleeding. I can take this flap, I can walk out from this room with the flap in my hand. So when I look at the patient like this, I know it should not be a technical issue. Okay? Now we're going to go to the buccal and around the nerve. This patient had several surgeries before, so this tissue is not native. The non-native tissue is much more difficult to work with. You have to be very careful and patient. So I'm going to go and carefully cut the periosteum. And after that, once I cut the periosteum, I go around the nerve, and I would say 3 to 4 millimeters close to the nerve because the flap is very short, coronally. And then once I did that, I changed for the new blade, which is a 15 blade. I'm going to twist the blade, and I do the so-called debundling. Okay, and you can see I'm just using the tip of the blade. Here is the mental nerve. I don't want to expose the mental nerve. I don't want to take branches out and take pictures of it. I just want to advance the flap without ever seeing the nerve. So very carefully going through that. And I will stretch with the blunt instrument. And that is basically the flap advancement. The flap advancement, we're not using the blade anymore. Okay, because again, it's very, very critical not to damage the nerve. So now you can see that it's all up. In the mesial part, we're going to do like a collagen membrane. We're going to cover the whole thing with a collagen membrane. Then we're going to secure this in 2 layers. Okay, we use a 2-layer technique all the time, and then is a primary closure. Very good. So, but when this patient comes back, you can see in the middle that here, where there was a bony wall, the bone is perfect, but here is not very perfect. So we also look at that histologically, and we call this the so-called smear layer. When we see that, we empirically started to use something called the mini sausage. We place the implant, and we do a protecting layer of bone graft, which is the same composition as the original bone graft, on top of this, because we know histologically that this is bone. So we put bone on top of bone, that should be bone, and there is bone. And now I have 3 13mm implants placed, and you can see that this bone is beautiful, is vascularized, is wide, and it's high. And this part of the mandible did not exist before. Okay, and this is how the patient is today. Good, here's another one. Okay, now you can see that the young patient, anterior teeth, not very good, but the bone is so narrow that basically forget about intraforaminal implants. So you need a bone graft, but now you need a bone graft from a very poor host that is very thin, very narrow, very cortical, and you want to put like an implant in the air. So here's the bone before and after. And here you can see the bone, the defect before and the defect after. Let me show this to you again. The defect before and after. Okay, it looks pretty hard to me. So this is the extreme vertical atrophy. Okay, these patients were coming after several surgeries. We do the same thing with them. I just want to show you another one, how beautiful, vital, and cortical it is. And it's the patient that I introduced the lecture with. And you can tell that this patient has the anterior mandibular defect. We're going to do the bone graft. Okay, we do the lingual flap advancement. We do the fixation of the membrane. Then after the lingual flap advancement, and you can see on the right side, I'm gonna evaluate and find the end branches of the sublingual arteries. I love them. Look at them. I like to play with them all the time. So here it is. Here they are. And here we go. Okay, good. And then this is how I'm going to close the flap now. Don't have time to show that. And here is the bone. I'm going to just refresh on this. I'm going to put in the implants. Here we go. Let me show you this. It's faster. Look how vital this is. And that patient looks like that today. And I'm much more comfortable with this bone over time than what the patient originally had. See that? I'm much more comfortable with that. It's going to remodel a little bit. I don't have time to go into the big defects in the maxilla, but just look at this patient. This patient is about 10 years younger than me. This patient had an accident 18 years ago, and they told her, forget it. One surgery with the membranes and intraoral bone grafting. I just want to show you the face. Here's the bone. Here's the surgical guide, and here is the face. And now she is 10 years younger than me because the bone is going to support. The bone is going to support this patient perfectly. Okay, how does it look over time? Okay, here's the defect before and after. Here is 10 years. Here's a patient before and after. Here is 16 years of follow-up. Here's a patient, a gigantic defect. Half of the maxilla is missing before and after. And here you can see I could place, I mean, this bone doesn't want to go anywhere. This is 10 years. Look at the cross-sectional view. And here's a patient that we grafted after 10, and this after 15 years. And so basically, what we can say in the last few minutes is that I think the vertical ridge augmentation with GBR is predictable and safe. And I think we have to explore the extreme vertical atrophy, because I think no matter that it's not in the literature, I would have to say that it is possible to do. It's just takes a little bit more, finesse, maybe a little bit more patience. And also you have to get the right indication. If a patient doesn't need it, don't do it, okay? But if the patient has perfect teeth in the front, I don't think you should be extracting those teeth, okay? And with this, I would like to thank you very much for the attention.
Super, thank you so much. I hope everyone can hear me because I had to switch my earphones. Thank you, Sarah, very much, Istvan, for your presentation. I think it was unbelievable. I think I could feel my heart beating while seeing your surgical pictures. It was unbelievable. And I think the audience thought more or less in the same way. And they had a couple of questions. And I also tried to summarize some of the questions that and try to condense this into topics. And one of the topics was regarding how do you handle the soft tissue? So what do you do on the lingual aspect? So what is your technique to advance the flap so much? You showed it in your video, but I think some of the people would really like to know.
It's difficult to follow. Yeah.
Yeah, because this is, I think, very critical to get the tissue back over the augmented area and then have it sutured back into place without any tension. I think this is something that people are really interested in.
Yeah. So basically, in the there are several techniques has been described to do the lingual flap. Okay, and I think most of the techniques can be used, but I think once you go to the extreme vertical defect, the technique that we use that we call the modified lingual flap is really based on the anatomy. And in the anatomy, you have 3 lingual zones. There is one that is the retromolar pad. There's another zone where the mylohyoid muscle is very close to the crest. And there's another zone from the premolar to the anterior where the mylohyoid muscle is far away and there is a very rigid periostal layer. And so we have 3 steps for the 3 zones. The first step is that we tunnel and lift the retromolar pad. And that de-anchors the flap from the back. The second step is that I think is very well visible in this video, that we separate the flap from the mylohyoid muscle. So we just gently push it off. And this comes from the basically 3rd molar to the 2nd premolar. But then more anteriorly, and this patient was really more anteriorly, there is a periostal layer. In the periostal layer, we use the back end of the blade to go through the periostum deep down, so that where the flap is not thin, but it's already inside the floor of the mouth. So we go deep down there, and then we just gently scratch. And then we open that periostum up, and then we put a blunt instrument and just push it up as it was maybe visible. And then the whole thing, all the 3 zones comes up like this. And then around, the buccal, I think the mental, and what we do in the mental nerve is also very important, that we don't cut basically anything, only the periostum, and then we just stretch.
Yeah, super. In this context, people were asking, how do you perform the suturing technique? So you talked about the double layer wound closure. I think most people know it or heard about it, but maybe you can explain this to the audience.
Yeah, I think it's a very good question, because I see that out of 20 people, 15 are suturing with a double layer closure. And I'm looking around the 15, 12 I don't like, because they're pseudo double layer. So the difference is this or this. And many times, especially in the anterior maxilla, they do a lot of this, and then the whole thing open up. So we use the PTFE suture. Maybe you don't have to, but I don't know, because I always use the PTFE suture. We go after the flap advancement in the middle of the membrane. We go 5 millimeters away, depending with the defect size, but a big defect, 5 millimeters away from the incision. And it's a 5 millimeter rule. We do a horizontal mattress. Everything is 5 millimeters from each other. And we put at least 3 to 4 of those in. And then the whole thing comes like that. And the rest is just single sutures to hold the edges. But basically, these 3 sutures are holding the entire flap.
Yeah.
Those are the holding sutures.
Yeah.
And my recommendation is don't complicate that more than that. Okay. It's very simple. That's the problem, is that we when something is simple, we don't want to believe it. It's like, I want to complicate it, and it just gets worse.
Yeah. And as you can imagine, there are also a couple of questions regarding the graft augmentation. So in the augmentation itself. So people were asking, where do you collect the bone? So when you do your grafting,
I cut it out from this video because of time.
Yes, of course, I can imagine. And people were asking, what is the mixture? So how many % you use autogenous bone versus xenografts? And so what is the mixture? And for how long would you wait prior or wait for the re-entry and placement of the implant?
So basically, depends on, number one, where do we get the bone? Most of the time we get the bone, we always intraoral, harvesting intraoral. Most of the times we harvest the bone from the retromolar area. Okay, it's very, very, before, when we did only autogenous bone, we did a lot of chin grafts, which is, much more invasive. But so we do the retromolar area. For this type of defect, for this patient, this particular patient, you could see that in the right side of the mandible, there was hardly any bone. So I collected the left side from the left side of the mandible, but I was also able to collect from the right side a little bit with a little trephine and we have a trephine that stops. So we measure where the nerve is, and let's say the nerve is 6 millimeters or 4 millimeters. Then I take a one that is 3 millimeters or 2 millimeters. It's gonna, I mean, that probably the 3 millimeter one is the shortest one. So then I go laterally and I will stop. It stops automatically. Okay, and then I take that and I put it to the bone mill. I also use a scraper for mostly like horizontal defects. We only use a scraper. And when do I place the implant? I showed you the video that was two sides from the same patient. One side you see the corticalization. That was too late. Okay, that patient could have been loaded already, but the patient couldn't schedule. So for the horizontal defect, 6 months is enough. Maybe 4 months is enough. And some people want to place their implants at 3 months. But to me, is, you know, I know that how the bone is growing. And I know that sometimes they place implants in 3 to 4 months, but I look at it and I know that that bone is not ready. So then they're going to go in like, do soft tissue, you know, and then, but usually what we do is like, let's say I place the implant at 6 months. I recognize maybe I need a soft tissue graft. Then I do the soft tissue graft during the implant integration time. Okay, then, so that's for the horizontal defect. The vertical defect depends on the size of the vertical defect. Yeah. For me, I only look at what is going to happen over time. I don't care gaining 2 months or 3 months. I care what happens in 10 years. So we're very, very careful. Okay. What I see with the new membrane, that our bone quality is so good that is like, probably I could have placed that implant, I would say 7 months in most of the average vertical defect cases, but I still go 9 months because of the old classical rules. And until you do like a randomized clinical trial, it's all anecdotal. Okay.
Yes.
So,
right.
but I would say that what is the time tested? The 9 months is for sure time tested. Okay. Now, when do we do a mini sausage? The mini sausage we do for the extreme cases and for the anterior. Okay. I also put some anterior cases, but I didn't have time to show that. But in any way, so what you see is that you can put a little protecting layer of bone graft that really stabilizes the crest of the bone. And
if you have such high vertical augmentation, what is the long-term prognosis? Will it be stable over time?
Yeah. Okay. So I know that the normal vertical defect is going to stay stable. I showed you some extreme cases after 10 to 15 years, because I don't know if you looked at, but half of the maxilla missing over 10 millimeters of bone. That we call defect that was not published in the literature. Only maybe some cases inside, you know, in a case series. One of them was like that. So there's not like a publication when there was, let's say, 20 cases only extreme, let's say only in the mandible, and a follow-up of, let's say, 5 years. There's no such a publication, but there should be. Okay. I'm very, I would say, very optimistic because of the cases that we do now, and we have the old extreme cases that they're doing great, but we have the new extreme cases after the, you know, untreated periimplantitis, when the patient's coming like, and his whole thing is demolished already. It's too late to try to save the implants, and you know it's very cortical. So I mean, yeah, that we still need to collect more data on that.
Yeah.
But also I'm carefully optimistic because of the you know, we also believe that as Giovanni and also Daniele was talking about, that, you know, the soft tissue integration is very important, you know, and manipulation of, you know, and potentially soft tissue grafting, and so for the long-term health of the implants. But you know, because the vertical defect is so unforgiving. If it doesn't want to stay, it's not going to stay. So you have to make that bone like rock solid.
Yes.
And
so
then you, of course, you work with the soft tissues to protect the implant. But if the bone is not good, nothing is going to protect the bone and the implant.
Yeah, in this context, it would be interesting to know, not only to me, but to anyone else, what is the type of implant that you would prefer to place in such material that is, that's critical.
That's a question. So I think in the posterior, we're doing a randomized clinical trial because we classically place an implant that has a machine color, okay? And we place that implant inside the bone, okay? So let's say you select a tissue connection. That's let's call an implant that way. Let's say you have a 3 millimeter polished neck or machined neck, and you put it 1.5 because you say that you're going to lose 1.5. So you put that in and you guide the bone to grow down to the rough area of the implant. To use an implant that is all rough and to put it to the level of the bone is not the best idea, because this is what's going to happen. And if that happens in the posterior mandible and many implants, you know what happens after 7 years. So that would be, and then what we do and compare is that we do like this all rough implant. Currently we use one which is very smooth in the first couple of millimeters. We put that inside the bone, and we try to connect the abutments, you know, immediately and one time, and have enough soft tissue to protect. And what we look at that they both work pretty well. But if you place an implant that is all rough to the crest, forget it.
Yeah. All right, great. Thank you so much, Istvan. It was unbelievable, very exciting. And just as Danielle's presentation, also yours received very, very nice comments here on that chat that we have outside. And I would like to thank you again very much for the nice presentation, also discussion. And we have time later on to continue the discussion a little bit. And I would like to take the opportunity and now switch and announce our next and last speaker for today's webinar. And this one is our third speaker, Giovanni Zucchelli, Professor Zucchelli. He graduated from the University of Bologna, and he received his PhD in medical biotechnology. He's associate professor of periodontology at the University of Bologna, and he is very well known for his expertise in soft tissue management. And in this context, he will present us something with regards to what we heard before. And it's about recessions around implants and how to deal with the missing soft tissue around the implants. So please, Giovanni, the stage is yours, and we are all thrilled to hear your presentation.
Thank you, Eric, so much for the introduction. And I don't think you see my lecture. Do you see it?
Yes.
No.
Yeah.
Yes?
Yes.
Do you see me in the white picture? Yes?
Yes.
Yeah.
Okay. I'm very happy to be here, and thank to Quintessential family for inviting me. And since it's quite late, I want to limit my lecture and to give you some details regarding one of the approach we can use for treating soft tissue recession around the implant. Is the most frequent approach I use. There is also others approach, but it's much more rare and also much more complicated because you need to submerge the implant. And I prefer to give you some more precise and detailed information instead of to spread to different technique and nothing can remain in your knowledge. But it's very important for me, first of all, to say that it's very frequent that we hear buccal bone dehiscence, and buccal bone dehiscence means that there is no bone at the buccal aspect of the implant, but the therapy for this type of lesion is very different in relation to the implant positioning. So if the implant is placed in the right position, which means more palatally with respect to the position of the bone, yes, we have the space for bone grafting, so to regenerate the bone that was lost, and also to have bone integration at the buccal aspect of the implant. But this is a completely different situation from that one in which the bone dehiscence is caused by a mistake in implant positioning, and it is the implant that is placed outside of the bone housing. In this case, there is no matter to augment the bone because it is the implant that was placed bad. And so if you want to have bone at the buccal aspect of this implant, you have to remove the implant and place it more palatally, and then you have space for bone regeneration to become possible. So with the same name, buccal bone lesions, most of the time we make a big mess because it's completely different if you have buccal bone lesions due to bone loss or if you have buccal bone lesions due to bad implant installation. So only those lesions in which the bone is lacking because of something happens to the bone, but the implant is placed in the right position, we may have space for bone regeneration. While if the implant is placed outside of the bone housing and we don't want to remove the implant, the only thing that we can do is to augment the soft tissue thickness so much this tissue is so thick that will not receive, it will not go back into the apical position because it's so thick that is thicker than the inflammatory area that is occupied by the inflammatory cells due to plaque accumulation or due to brushing trauma. So the situation in which the implant is placed outside of the bone, it's very, very similar to the situation in which the tooth is placed outside of the bone. And I'm really wondering why, when you have a tooth that is placed outside of the bone, why don't you make bone augmentation in this case? While if the implant is placed outside of the bone, there is somebody who says that I can also augment the bone, while if it's the root, you don't augment the bone, but you only make soft tissue augmentation. I think that the two situations are very, very similar. This is a buccal bone lesions due to bad implant installation or to very, very buccal position of the root. And in this situation, since we don't want to remove the tooth and we don't want to remove the implant, the only thing that we can do is to make soft tissue augmentation in order to cover the exposed root surface. So this is a buccal bone lesion due to some bad positioning of the tooth or bad positioning of the implant. So we have many, many similarities in the treatment of the lesions around implant and teeth, but obviously the most important difference is that in the case of teeth, we have the cement enamel junction, that is the goal that we want to achieve. So we want to cover the cement enamel junction of about 1 millimeter, while in the case of implant, the level of coverage is different according to the tooth we are treating. If you have a lateral, we want to have the lateral that is shortened than the central, than the canine. So it's aesthetically guided, the level of coverage. We don't want only to cover the metallic surface, but we want to re-give the implant supported crown a transmucosal zone. And the problem is really the crown. So this crown, it's so buccally displaced because the implant is so buccally displaced, and so the crown is even more buccally displaced, that we don't have blood supply enough to give coverage to this crown, especially because we don't have any interdental soft tissue support. And how much the absence of bone in the cone beam influence our decision-making process, I think it's important to know. So I think we need a cone beam in order to see how much of the implant is placed outside of the bone, but more important than how much of the bone that is lacking at the buccal aspect, is important to understand if this bone, if this surface that has no bone at the buccal aspect of the implant is also contaminated or not. Because you know, if you have a lot of implant surface that is contaminated, we have also the problem of the decontamination, which is not always so predictable. While in most of the cases, despite the complete absence of the buccal bone, there is no probing pocket depth at the buccal aspect. And this is because the soft tissue is perfectly integrated into the very rough, complex implant surface with fiber integration or connective tissue adhesion. You can call it whatever you like, but it's something that is, let's say, adherent, if you don't want to say attached, that don't allow the bacteria to penetrate. And in this surface, you can see that despite the complete lack of bone, there is the very, 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 very clean implant surface, because this surface have never seen one bacteria in its life. And this is because the connective tissue integration was so useful to protect the implant surface from the bacterial contamination. So it's very important to distinguish if we don't have bone, but we have also implant contamination from the situation in which we don't have bone, but we have connective tissue integration. So we don't have to treat the implant surface and we don't have to decontaminate the implant surface. Obviously, we have to cover it in order to increase the thickness of the tissue, where the thickness is never enough. It's never enough, because in order to cover the metallic surface and to mask the transparency of the surface, we need more than 2 millimeters of soft tissue thickness in so apical the dimension, and so we don't have, and so for sure, we have to make a connective tissue graft. But this connective tissue graft will never survive on the crown, on the abutment, on the implant metallic surface, and so we need to cover this with the coronally advanced flap. But the problem is that with respect to the ideal position of the connective tissue graft, which is 1 millimeter more coronal than the ideal position of the soft tissue margin of the implant supported crown, and which kind of connective tissue we are speaking about, it's a connective tissue taken from the posterior palate, coming from the desepithelialization of the free gingival graft. The problem is that we don't have blood supply for the covering flap, because these papilla, even if they are perfectly present, they are very, very narrow, very, very palatal with respect to the position of the crown, that it's so buccally displaced, and it's extremely, 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 extremely thin and not supported most of the time by the completely healthy bone, as it happens for the case of teeth. So we have to improve the situation at the level of the papilla, and the best improvement is done by removing the crown, changing the abutment, making a very, very narrow, thin abutment, and leave with the short temporal crown the time for the soft tissue to fill the space that was previously occupied by the old crown. And what this is able to create is to change completely the shape of the papilla from a triangular to a trapezoidal shape, that thanks to the presence of an isthmus, which makes the buccal and occlusal surface of the papilla to be continuous, we can also extend the desepithelialization of this anatomic papilla towards the palatal aspect onto the occlusal surface in order to increase a lot the blood supply for the surgical papilla. So the graft must be desepithelialized, but also the area of the papilla has to be desepithelialized towards the most palatal aspect in order to improve so much the blood supply for the surgical papilla of the coronary advanced flap. And this is the key in order to maintain the connective tissue graft coverage at the level of the surface that is completely avascular. So it's not enough to make a surgery. We have to remove the crown, remove the old crown, change the old abutment, select the smallest and the thinnest abutment as possible, place a very short temporal crown, and leave the soft tissue fill the interproximal tissue until the whole area is completely filled by soft tissue. And this takes time. No less than 2 months, but sometimes even 4 months are necessary for the soft tissue to completely fill, especially if the implant is very, very close to one of the 2 adjacent teeth. Now, the surgery is very similar to the surgery we make for the teeth. We make the horizontal incision at the distance from the most palatal aspect that is the same of the flap advancement in the middle. And first thing that we have to do is to sign the bleeding line and make a trapezoidal flap design with 2 horizontal and 2 vertical release incision. Obviously, we have to remove the abutment in order to facilitate the blade to be completely parallel to the external surface, because in this case, there is no bone, like for teeth, to keep the blade so superficial parallel to the external surface. So the split thickness elevation of the papilla is better to perform with no abutment in situ. And so you keep the blade very, very superficial in order to maintain the same thickness in the entire surgical papilla. But now there is the most important difference. We have to make a split thickness elevation of the flap where there is fiber integration. We don't want to destroy the connective tissue that is integrating between one thread and the other, and we don't want to have any, let's say, perforation of the flap. So we have to make our incision between the flap and the implant surface to detach the connective tissue fibers and preserve as much as possible the connective tissue integration. But the most important thing that we have to understand is that if we have connective tissue, if we have fiber integration, this is very important because it means that we don't have to make any decontamination of the implant surface. And this is something I knew even before when I tried to probe this buccal surface of the implant, and despite the complete absence of the bone, it was no way to probe the buccal aspect because there was good quality of adhesion between the connective tissue and the implant surface. So it's not enough to make a cone beam in order to decide if the implant has to be removed because it's completely contaminated or exposed at the buccal aspect. Now we can move to the flap advancement. So first of all, we make the deep incision to remove the muscles from the periosteum. And then once these muscles are detached, we make the second, which is the most important incision of all. And this is the superficial incision, keeping the blade parallel to the external surface in order to remove all muscles belonging to the inner aspect of the alveolar mucosa, and all scars tissue, all materials that was placed above the implant that is not integrated must be completely removed. Now it's the time for the abutment to come back, because we need the correspondent of the suprabony component of the root at the level of the tooth in order to apply the connective tissue graft in the right position. And the connective tissue graft should be applied 1 millimeter more corner than the ideal position of the soft tissue margin. And to apply the connective tissue graft in this position, obviously, we need a smooth, convex, and absolutely clean surface. And this is the abutment, surgical abutment. Once the surgical abutment is in position, we can make the desepithelialization of the papilla, and this is done with a blade first, and then towards the most palatal aspect with the microsurgical scissors in order to create the biggest vascular bed for the surgical papilla of the coronally advanced flap. How do we take the graft? We take a free gingival graft that is desepithelized extraorally. And what is different between teeth and implant is the apicocoronal dimension of this graft, because in the case of teeth, 4 or 5 millimeters of graft is more than enough. In the case of implant, we have to cover the all metallic exposure in order to mask the transparency and increase the thickness of the graft also more apically. And the desepithelialization is done, but first of all, we have to remove the olfactory and glandular tissue from the inner aspect of the graft, and this change from patient to patient. We don't want to leave any mobile tissue between the graft and the implant, but we want to improve the fibral integration, which was already also present before, but now we want to increase the thickness of this. Now it's time to fix the graft, and also for this, there is some changes. Why in the case of teeth, it's enough to make a single interrupted suture. In the case of implant, we have to anchor to the palatal aspect with some horizontal mattress suture. And since the graft is so big and has some tendency to be detached from the periosteum level more apical, we have also to fix the graft more apically to the periosteum by means of an external periosteal anchorage that gives us the possibility for the graft to be applied on the periosteal bed. And this is very important to give blood supply. So also the dimension, but also the way of suturing the graft change, because we have a much more buccal displacement of the implant with respect to the tooth. Same rules for the flap. First of all, we close the vertical release incision, but in this case, the surgical papilla must be displaced coronally to reach the most palatal aspect of the anatomic papilla. And in this position, we start to close the vertical release incision. We start at the level of the mesial, and then we go distal, and then we jump from the mesial into the distal. The final suture is also different because we cannot make sling suture around the palatal aspect of the abutment. It's that it does not give enough retention, but we have to achieve the anchorage by using a sling suture around the palatal aspect of the two adjacent teeth. And this sling suture is really critical to achieve a horizontal compression by the suture material surgical above anatomical papilla into the palatal aspect. So one suture is around the mesial, and the second suture is around the palatal aspect of the distal tooth. And when you close this, you see that the surgical papilla goes palatally and is compressed above the anatomic disepitalized papilla towards the most palatal aspect. Finally, we have to improve the first intention wound healing closure between surgical and the anatomical papilla, very, very close to the abutment. That is the most delicate area, because we really have to achieve the greater amount of first intention wound healing interproximally in order to allow the flap to survive on a buccal aspect that is completely avascular. So one single suture mesial, one single suture distal. And now the flap is advanced, is covering the connective tissue graft, the temporary crown is reduced, and again, we don't have to be in a hurry. We have to wait. We have to wait for soft tissue maturation phase. And the soft tissue maturation phase lasts about 4 months, in which we don't have to do anything else than change, then remove the temporary crown, clean the abutment, and leave the soft tissue grow in thickness and in height without disturbing the healing phase and the maturation phase with the temporary crown, because it's a very delicate area. Don't forget that the soft tissue is covering an abutment and an implant that is completely avascular, thanks to the blood supply that the soft tissue receive interproximally. So once the tissue has been increased in thickness and it's stable, so we are about 4 months from the surgery, it is the time for the next phase. The next phase is called conditioning phase. And this is a phase with some temporary crown. It's better to use screw retained crown. We reshape the tissue, reapicalize the soft tissue margin. We squeeze the papilla again by making some conditioning of the interproximal tissue, adding some composite flow to the temporary crown, changing the shape of the contact point until also the papilla goes back to the nice triangular shape. This is the time for the final restoration that obviously and unluckily is cemented, because it cannot be screw retained, because the implant is obviously still too much buccal displaced. So this is the first healing. The patient is very happy, because don't forget that the only alternative to this case was implant removal and starting everything from the beginning. So the patient can also accept some minor aesthetic, let's say, defect due to scar, which is mainly due to the previous surgery that has been performed at the time of implant installation. So this is really a very, very safe procedure, which makes the patient extremely happy. But obviously, we need to make the whole procedure from the pre-surgical, pre-prosthetic phase to the surgery to the post-surgical phase in order to achieve good aesthetic and good outcome. And this is the outcome of the 5-year study, which tells you that this procedure is very long-term stable. And if there is a difference between 1 and 5 years, is the further increase in the soft tissue thickness with time, which is absolutely typical of this procedure when you keep the connective tissue graft completely covered. What is the limit of this? Once upon a time, the limit was when the implant is so buccally displaced, then the screw connecting the abutment to the implant is too much apically. The implant was to be removed 100%. But now, thanks to my restorative dentist, who is Dr. Monaco from Bologna, we were able to have new type of abutment, which is in one piece capable to correct until 40-45 degrees of bad implant placement. And this is a typical example of extremely bad implant placement with no problem of the buccal bone. So it's not true that all patients around the implant depends on the lack of bone. Most of the time it's a bad inclination, not only a buccal displacement of the implant, as in the case of before. This was a case that once upon a time was to be extracted. Now we have this type of abutment that correct the previous one. Once upon a time, the screw connecting the abutment to the implant was in this position, so too much apical, to have a nice cannon to be restored in this case. And now we have in one piece completely shift the screw very, very corner. So even in this case of more than 40 degrees of bad implant installation, we can correct. And now we have a very smooth surface onto which we can apply our connective tissue graft. There is good papilla that we can use for the complete coverage of a tooth, or let's say of an implant that was really very, 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 very bad place. So there is also some prosthetic improvement, and I think this will also improve with time, that can give us some more possibility to keep this implant, that also from a psychological point of view, it's something that the patient appreciate a lot. Let me just conclude, because most of the time the question is, do this work only for single implant? And this is not true, because this depends mainly on what is the distance between the two implants. If with the pre-surgical phase, by narrowing the abutment and using a very, very short temporary crown, we are able to create a papilla, even very, very flat, that can be desepithelialized towards the palatal aspect. These implants can be treated even if there is two implants close to each other. What is the critical aspect is not how bad the implant is placed, but if there is the possibility to extend the desepithelialization of the papilla towards the palatal aspect, not only mesial and distal, but also in the inter-implant papilla. So the desepithelialization and the width of the papilla between the two implants is the key in order to be able to advance the flap so palatally and so cornally to cover a connective tissue graft that obviously must be bigger, because it has to completely cover the dehiscence and the bad position, especially in this specific type of implant that is very difficult to be covered, because they have the transmucosal zone that is very, very divergent and very, very buccally displaced. The graft must be perfectly fixed, exactly like Istvan said. For the membrane, the graft must be really perfectly fixed, and so it has to be closed mesial and distal apically to the periosteum in order to provide really a very, very good coverage in the very, very critical area that is very, very coronal. But again, this graft will never survive if it's not completely covered by the coronary advanced flap. But the coronary advanced flap can be closed thanks to the first intention wound healing interproximally to the palatal aspect in order to achieve coverage of this graft, despite two implant was placed so bad and so buccally displaced. And due to the presence of the graft also between the two implants, the increase in the thickness buccal lingual of the tissue makes also the papilla grow in apicocoronal direction. But it's not enough to wait 3 weeks, 4 weeks, 5 weeks, 6 weeks. You have to wait 6 months. You have to leave the soft tissue maturation phase to be completed in order to start the conditioning phase. And it is really the buccal lingual increase in the soft tissue thickness that will promote also papilla growth between the two implants and will give the possibility to our patient, our patient to again have a papilla and the right dimension of the two crowns, implant supported crown. And let me conclude, because this one, I know that I love you so much. I didn't get exactly what you said, but you said in your lecture a sentence like this: dense connective tissue protect, I don't know if you said danger, more like this, from the dentist, yes or not? And what I can add is that dense connective tissue graft also protect danger from the dentist. Thank you very much.
Oh, dear Giovanni, thank you so much for this unbelievable presentation. That is always very exciting to see all these beautiful pictures and movies. And as you can imagine, there were a couple of questions that came in during your presentation. And I would like to take the opportunity and say to everyone that we have reached over 3,700 people watching this webinar on Facebook or Zoom, which is incredible, I think. So again, thank you very much. And there are a couple of questions. And
Eric,
yes.
Can I have the pleasure to ask the
Yes,
first question?
I wanted to switch
Giovanni?
to you. You have to take the opportunity and have to answer the question, or you have to ask a question to Giovanni, of course. Please go ahead.
Yes, Giovanni. You know that when we treat gingival recession around teeth, we plane the exposed root surface coronal to the deepest point that we can probe. I was wondering, how can we be sure that the implant surface is clean and is not contaminated? Because I'm seeing in the videos that you don't treat the implant surface that is without the bone with any kind of treatment. So we just believe in, is enough to believe in our eyes, or because if we probe, there is no attachment over there.
I don't think it's a problem of eyes because you don't see anything. It's a problem of probing. But this is the same for teeth, dear friend. Do you probe the bone crest when you probe the buccal aspect of the tooth?
No,
Or
but
do you probe
around
the
teeth, we know how
attachment?
much we have to probe.
1 millimeter, 0. You don't probe nothing if there is connective tissue integration. You don't probe nothing. You don't probe. If you try to penetrate where there is connective tissue integration, you perforate the soft tissue because the surface of the implant is more complex than the tooth. If you want to penetrate with a probe between the tissue and the thread, you are not able.
I lost you.
Giovanni, are you still there?
Yes. No.
Giovanni,
Yeah,
maybe.
he's not there anymore. Oh, he
He's
disappeared.
gonna come back.
Too late.
What he was saying, yeah.
So,
that
but
if you don't probe,
I see
there is an
Istvan.
attachment. Giovanni, you back?
No, sorry.
Giovanni.
so is Giovanni back on?
Yeah.
He's back.
Oh yeah, here he is.
What Istvan was saying, sorry.
No, I was translating what you were saying because you were gone. I was saying that if you don't probe, there's an attachment.
Yeah.
Yeah.
And when you do that kind
if
of,
you probe and you probe, it means that there is no any adhesion, obviously, and it means that the surface is contaminated. But if you try to probe and you are not able to probe because the probe do not penetrate, it means that there is something that don't allow the probe to penetrate. And what is this something?
so with the kind of thin tissue, if we probe 25 grams as we do around teeth, we don't go through.
Okay.
Yeah.
So there were some questions from the others, and Giovanni, people were asking about the choice of suture, and what do you use for suturing your connective tissue graft? And also, could you comment a little bit on the technique of suturing?
Yeah, the connective tissue graft is sutured with a 70 PGA suture, which is a very, very thin suture material with a very, very small needle. And this is very important in order to be able to engage the graft and the papilla in a very, very short space. I like to use resorbable suture also for the, let's say, for the flap. And this is because my flap and my papilla is very thin, and I risk if I use, let's say, some more rigid suture material to become, to risk to cut the tissue. And I don't want to have any risk to cut the tissue during the healing or when I pull the suture in order to be compressive. So I prefer to use very, very thin suture material that is, let's say, not the best material for plaque accumulation, but we are speaking about patients with no periodontal disease in the buccal aspect, with chlorhexidine in use. So I prefer to use braided suture that being coated accumulates plaque, less plaque than, let's say, monofilament, more plaque than monofilament theoretically, but it's also much softer. And so there is no risk to be traumatic or to cut when you make the knot or when during the healing. So I prefer to use PGA suture, but it's very, very thin. It's 7-0 suture. The only difference is that I use a very small needle, about 6.5 millimeter long for the graft along the vertical releasing incision, and 11 millimeter needle for the sling because I have to reach the palatal aspect.
Yeah, yes, of course, yes. And the questions were also about the connective tissue graft. So do you collect your tissue graft always by removing the whole tissue, or do you also perform trapdoor technique? Was one of the questions. And in which situation would you use what technique, and what it would be in this context the ideal thickness of the connective tissue graft that you would like to have on an implant?
Yeah, I personally use this technique, let's say 100% of the cases, because if I use a connective tissue graft, it means that I need it. So, and you use the connective tissue graft in this case for implant to give stability to something that in the suprabony component, let's say in the area of the transmucosal zone, is not attached. So it must be really thick, more than 2 millimeter. And so I want very dense, collagen-rich connective tissue that must be absolutely stable. And when you use other technique, you go deeper, and so you take a connective tissue that is not as dense as the same one you have immediately below the epithelium. Concerning the thickness, this is very important because we change a bit. Now we measure the thickness of the flap at the time of the surgery, which most of the time obviously is very thin. And so we want to add a thickness with the graft that makes with the flap 2 millimeters of thickness, both. I mean, if the flap is 0.5, I take 1.5 millimeters of connective tissue graft. If the flap is 1 millimeter, I take 1 millimeters of connective tissue graft. So that flap plus graft make 2 millimeters. And this is because what we saw is that with time, this combination by the graft plus the flap and this specific type of graft make the soft tissue continues to increase with time. And so we have the opposite problem most of the time, that there is too much increase in the thickness with time. And so we can reduce the thickness of the graft at the time of the surgery with respect to what we were using in the past.
Yes, all right. Thank you so much. So everyone can imagine with 3,700 people on Facebook and Zoom, we are not able to answer all the questions, but we will try to collect questions and find answers with the speakers and then maybe send it out later on in an email. So don't worry. So we try to capture all the questions that have been asked. But for you, Giovanni, there's one of the questions that people would interest, because sometimes you have an infected or an inflammation at the implant site. So if it's not clean, what do you use to clean it? Or do you do an implant plastic, or what do you do with the rough surface versus the smooth surfaces? Is there any recommendation to the people what they can do when it's infected?
Yeah, let's say that the surface is infected when it is exposed. That's when exposed to the oral cavity, I mean, or when it's probable. And so you probe between the tissue and the implant, and obviously it means that there is contamination. And in this case, obviously we have to decontaminate the implant surface, and the instrument I personally like to use is the microbrusher, a titanium microbrusher for the mechanical clean. And then I also add some chemical clean with ADTA and chlorhexidine gel. But this is, let's say, some very, very personal way of decontaminating of the implant surface. I have to tell you that I'm really very positive with this approach, especially with the micro titanium brusher, because it's not implantoplastic. They don't change really the shape of the implant, and they leave the macro, the thread, and also the micro implant surface by removing external layer. And with this external layer that you remove, you also remove the biofilm, but they don't change completely the shape of the implant. So I don't like at all to make implantoplastic. If I have to make implantoplastic in the frontal area, I really start to think to implant extraction. Yeah. And if the implant is contaminated a lot, it's also let's say, more risky to keep the implant, because if you're not able to decontaminate it completely, you can make coverage, but making also a big pocket that it's not possible for the patient to clean. So I think that the presence of contaminated or not implant surface can make really the difference in the decision-making process. But my protocol is chemical treatment with microbrushers and, mechanical treatment with micro titanium brusher and chemical with ADTA and chlorhexidine gel.
Yeah, thank you very much. Before we invite another one to ask a question, there's one maybe a very short question. Is it also possible to use this technique if one of the papillae is lost, maybe at the mesial or the distal side?
No, this technique is not possible to be used in this case. In that case, you have to submerge completely the implant. And so to use the papilla like an edentulous area, so you have to remove the crown, remove the implant, place an healing cap, leave the soft tissue submerged as much as possible the implant site, treat the implant site as an edentulous site, so to make soft tissue augmentation in the edentulous site. Don't forget to take an impression of the implant head, because once the soft tissue has been rebuilt, you have to punch in the middle, very, very guided with a surgical stand, so to rescue the head of the implant. And there is no way to increase the papilla when the papilla are lost, despite to increase the soft tissue in the dental site. So it's a submerge approach, which is more difficult. And let's say, also, we don't have so many data about this. We have much more data on the prosthetic approach. So to increase the papilla, it's possible, as Istvan was saying, but this doesn't mean that it's something that is predictable.
Yes, okay.
Yes,
Daniel.
Can I have a second question for Giovanni?
I don't think so.
Okay, you get one short question, and then we want to switch to Maurice Salama, who is also having a question for Giovanni. So please, Daniel, one short question.
Giovanni, how do you put your patients in the maintenance care? You know, all that amount of soft tissue. Somebody else will call pocket. I don't want to push you on this, but maintenance care.
Pocket is something that you have to probe, not to say. But I mean, the maintenance is the same maintenance on whatever patient that makes, let's say, soft tissue augmentation, that makes regeneration procedure. And I don't think that the presence of a transmucosal zone in the aesthetic areas at the buccal aspect, it's something that changed the frequency of the recur. I think the patient must be judged in terms of plaque control in the area where it's more difficult for the patient to clean, not for sure the lateral incisors of the upper jaw in the buccal aspect. So for sure, the frequency, it's very, very important, but it's something that depends on the capability of the patient to clean. And so there are patients that comes to my office every single month because they are not able to clean, but this is not the right patient for this treatment. There is patient that comes every 4 or 5 months, and because they are so good, their plaque control, it's so good that I can give them the possibility to come 3 times a year, no more. So it's something that changes from patient to patient, but this is true. I think it's more difficult to maintain the posterior segment when you make, let's say, bone augmentation, you have an implant in the regenerated bone. This is much more risk problem for the patient if the patient is not good in plaque control than in the frontal area, the buccal aspect of the lateral incisor.
Right. So we have one short question for Istvan. There's someone asking about the exposure of tissue during healing. Maybe you want to answer this question during Christian is inviting Maurice Salama to ask his question.
So probably the question is exposure of the graft or the membrane during the healing. So we have to do everything to prevent that. That's the most important. If you have an exposure, there are 2 types of exposure. One is an early, one is a late. And what we really don't want to have is we don't want to have any of them, but we don't want to have an early exposure. There are 2 types of early exposures. One is a simple early exposure when you have, because of mostly surgical error, you have an open flap. The other one is the complex. Then you have an exposure and an infection. And that exposure can be secondary from the infection. So you treat the two things very, very differently. It's very important what type of barrier you have. The extended PTFE, the old Gore-Tex was not very good because the bacteria could penetrate. So the dense PTFE, especially the non-perforated, is probably the best because the bacteria is very resistant to penetrate. So if you have a simple exposure, that means that you don't see a visible infection, no pus. Probably there is some bacteria, but no real pus. Then a race begins between graft maturation and bacterial penetration of the bone graft. And so you want to clean off the exposure. I would recommend to give another course of a week of antibiotics coverage to the patient and try not to remove the membrane for at least 6 weeks. At 6 weeks, you will have a ridge, then take it out, or 2 months max. If you have an infection, treat it as an infection. Let's say you have pus, you have to open up and take the membrane out, and probably you can kiss goodbye to the bone graft.
Yeah, I believe so. So maybe, do we have Maurice already on board? Christian? Otherwise I can also ask the question to Giovanni.
He's there.
All right, he's there. Okay. So you can please go ahead and ask your question to Giovanni.
Yeah, no. First of all, I want to just tell you I enjoyed today very much, sitting here in Atlanta and letting you guys do all the hard work. It was really a lot of fun. But this is a great, I give a lot of credit to Quintessence, Christian, putting this together, and you guys making yourselves available. I thought you all did a fantastic job. Henrik, you did a great job fielding the questions, and what a great opportunity for people around the world to be able to, with very little else to do, but to educate themselves from masters like yourselves. And I included, I enjoyed it very much, learned a lot today. And I just want to compliment each one of you. Giovanni, I just had one question for you. I see a lot of people using microblades and bendable microblades. I see you don't really use them. And I also was wondering about one of the implant cases with the lateral incisor, that it appeared that there was some recession on the adjacent central. And I was wondering if that was part of the requirement for the patient, would you have changed your approach in terms of incision design?
In terms of, thank you very much for attending our meeting. It's an honor for us. The question regarding the microblades, it depends. It depends which technique I'm using. If I'm using a trapezoidal type of approach, where I have large papilla like that one for implants, I prefer to use the 15C. This is a specific 15C where the tip is very small, because this allows me to be more precise when I keep the blade parallel to the soft tissue and make only one cut instead of making different cut with a narrow blade. And so when you make triangular type of flaps and the tips of the papilla is very narrow, I prefer to use much more narrow blades. And the second question was regarding the central incisor. This is something that improved by itself thanks to the capability of the patient to roll in corner direction. And then if you look at carefully, there was a veneering also on this tooth. And so the zenith of the tooth was displaced distal. And this makes the patient very happy of the appearance with no need to treat also this small recession of the center.
But if you had a larger area of recession, how would you have addressed that from a flap design approach?
It depends. It depends, because, you know, vertical release incision is necessary when you have very, very flat papilla, like the case of the chew implant I show you. The only way to reach the palatal aspect, unfortunately, is to completely free the flap from the adjacent tissue with true vertical release incision, so the flap can reach the palatal aspect. And this
so would you treat them, Giovanni? Would you treat them then separately? Would you do the implant first, then come back and do?
I can do in the same time, but if one recession, let's say that one of the central, is very small compared to the advancement of the flap at the level of the lateral, in this case, I have to advance too much the flap at the level of the central, and so sometimes I prefer to do in 2 steps.
Fantastic. Thank you so much. I appreciate it.
But if the recession is deeper, it's easier because I can advance the flap coronal to the central and palatal to the implant. So it's easy.
Can I ask one more question? Giovanni, your vertical incisions, I never see any scarring. I want to know, could you give me just one little secret? I mean, really, it looks amazing.
The only secret is that you have to reduce them as much as possible. So during the flap design, I make very, very short, because when you make the flap design and you make the bevel, you risk to cut the periosteum. While then, after the first part of the flap, when I make the split thickness incision more apically, I can extend the vertical release incision, but only superficial, no deep. So I never cut the periosteum apical where there is alveolar mucosa. And so when I advance the flap, I can connect the flap to the adjacent tissue with a very, very superficial suture without taking the periosteum, which also creates scars. But this is changing by patient to patient, because if the patient don't have at all keratinized tissue of the adjacent tissue, it's very difficult to mask completely the scars. But it's also true that most of the time these scars is very apical, so the patient don't show them at all. While the scar I don't like is that one of the graft exposure. When the graft becomes exposed, it's completely different in terms of color, texture, and surface characteristics from the adjacent teeth, and this is something that the patient realizes immediately. So I prefer sometimes to avoid graft exposure and advancing the flap a bit more and making some scars apical along the vertical release incision than risking graft exposure.
Makes sense. Thank you for that.
But this is something that we will have time to discuss much more when I come to you.
I hope so. I hope so. I look forward to that. I look for. I could fill the next hour with questions for Istvan and Danielle, I'm sure, but I don't want to take more of the time. Thank you, guys. I really appreciate it. I enjoyed it very much.
Maurice, we will try to have you on at a certain point, huh? Why don't you?
It will be my pleasure, Christian. Be my pleasure.
Ciao, Maurice.
For chiming in.
Yeah,
Bye.
ciao.
Bye, Maurice.
Bye-bye.
Ciao, guys.
Yes, all right. So we have now completed our session, and I think it was very amazing. We had 3 very outstanding presenters tonight, and I have to, thank you very much, Danielle, for your presentation, Istvan and Giovanni. I think you 3 did just an amazing job, and I've just found out that I'm obviously be capable of following 2 chats in the same time, collecting questions. I didn't know that I'm able to do this. So I'm sometimes not even able to answer WhatsApp. So anyway, please allow me few last words regarding the situation, because we won't be here if there wasn't a virus in the world. And Danielle already said something about the Italian situation, and so we now have a worldwide situation where people are really suffering, and it's really a very severe virus, and it can be very severe to some of the people. And I think we have so many people here on board, 3,700 people on Facebook and Zoom, and I think they all are here, and they try to be strong and hold together. And I wish this for every one of us, to be strong and hold together. And I wish this to everyone in the world and who's watching us, stay safe and healthy. And also I like to thank in the end Christian for taking the effort and bringing this to broadcast. Thank you very much.
Well, thank you very much all for participating. That was fantastic. And I think we had a very, very good start.
Thank you also.
Good job, Christian. Thank you, Henrik.
This, I can just say thank you very much for participating, for taking the time, for being available to share with everybody on the internet your specialties, your knowledge, and it was a pleasure watching you. And I'm happy to do this again someday.
Yeah.
All right.
Me too. Thank you so much.
Thank you very much. All of you have a great couple of holidays. Some
Yep.
free days, hopefully with the family, and then we will see each other, hopefully in person very, very, very soon.
Yes, thank you so much. Great holidays for all of you.
Thank you so much, Eric, for the moderation. It was nice. Very, very nice.
Thank
you
you
so much for your job.
Very nice to see
Henrik.
you all.
Thank you, Henrik. Also,
Bye-bye.
thank you,
Thank you so
Giovanni.
much.
Thank you, Daniela.
Thank
Okay?
you.
You guys take care.
Ciao. Ciao.
Bye-bye.
Nice
Stay
to see
safe.
you all.
Stay safe.
You too. You too. Good to see you, Danielle. Bye.
Bye.
Bye, guys.
Bye, guys.